A little bit of preface to today's talk. Obviously, in the past year, we've been in a very, very unusual and tragic time with the pandemic raging around us, and all of our lives have been affected by the pandemic. Now, as a healthcare professional, we should know about what's been going on. And today, on the committee, some of us thought that it would be a good idea for us to start off by talking about the medical implications and complications and treatment of this disease, which, at the heart is an infectious disease. So today we've invited Dr. Christopher Steele to come talk to us about the medical side of things, which is a little bit unusual for us, at IOL and in the behavioral health network. However, the idea is that we want to build upon the knowledge that we get today in a series of different grand rounds, spanning the next year or two, really, to explore, now talking about the medical side of it, then talking about more of the neuropsychiatric presentation in the future. And I suspect at some point we will be talking about the long-term implications for both health and mental health as time goes on and we hopefully get past the pandemic and see the ramifications of the disease on the population health. So Dr. Christopher Steele is a longtime Connecticut native, and currently he is the assistant professor of medicine at University of Connecticut School of Medicine. He graduated with his MD and MPH from the University of Connecticut and completed his training in internal medicine at Johns Hopkins Hospital. He also has a lot of interest in medical education, and also his research is focusing on the bridging the gap of the social determinants of health and high-value care. And part of that also is related to mental health care. And he and I have many different discussions on, the kind of intersection between internal medicine, psychiatry, et cetera, and population health. He also has published in the literature on the topic of social determinants of health and high-value care, both nationally and internationally. He practices clinically as a hospitalist and primary care physician in the area. So in the past year, I know that he has personally treated many, many different patients with COVID. So without further ado, let's welcome Dr. Steele on giving us this talk.
Thank you, Dr. Zhao. He forgets to tell you that I was in his wedding party too, so he's being modest. He actually introduced me to his wife. We were classmates at UConn, class of 2015. He actually is the one who convinced me to get my MPH. So I'm here today. So I've evolved the talk a little bit. The talk I'm going to do is kind of a general overview of COVID. And I realized the reason why this is a good chat is even talking with internal medicine experts, ID experts. Well, ID experts tend to know this pretty well, but a lot of the internal medicine, family medicine, you name it, other specialties, they know roughly what's going on with COVID. But when you actually ask them to go a little bit deeper, they're like, I actually don't know. I know we do this and that here, and I know that COVID does, a few of these signs and symptoms, but I actually don't know what's been going on. And this thing rapidly evolves, as you know, daily. I get a message from Medscape almost daily about something brand new that's gone on in treatment, management, and so forth. So just to announce, I have no disclosures. These are the objectives that were sent out previously, which basically, in a really short summary, says basically we'll cover all the basics of COVID-19 infection. I like to actually go a little bit more simple, and I kind of want to have fun with this today, right? So the goals I want you guys to kind of take from this is basically after our conversation, I want you to feel comfortable answering your non-medical friends' COVID questions. So I'm sure just like you guys, I get called all the time, hey, so-and-so was just exposed to COVID, what do I do? Or I have an ability to get this vaccine versus this one, what do you recommend? Or I have this symptom, does it mean I'm going to die of COVID? And, a lot of the times I'm able to answer, but I'm sure some of the time, for myself too, sometimes I actually don't know the answer. So this was kind of a nice refresher to put all this together And hopefully you'll have that. And the same thing, too, is advocating for your patients. One of the things many of you guys know is not every one of your patients is robustly seeing a primary care provider or seeing a specialist beyond you guys. And you might be the person that they go to about asking a COVID question. And I think it's appropriate to understand, maybe not necessarily to be the one to start treating them, but I think it's the one that can actually start advising them where to go. And kind of, as I said, too, is, I want to create a strong foundation so when you guys have future discussions that you guys at least feel comfortable with the conversation going forward. And what we'll do is we'll do it in a question format. And I'm not going to ask anyone to answer the questions. I'm actually just going to propose questions, pause for a second, think about what you would put down, and then we'll go through the answer by actually going step by step. So the first one we'll do is COVID basics. So this is actually a real post I saw. I modified it slightly to make it a little bit more short. I'm sure we've all seen this post before on Facebook, Twitter, you name it. So a patient posted on their Facebook, and this was about a week ago for me. COVID-19 is a hoax. The death rate's around 0.001%. Why are we quarantining? COVID-19 is fake news. So I want you to think about this because this gets posted a lot by patients. What is the global death rate from those who've contracted COVID-19 to date, right? Is it 1 in 45 infected? Is it 1 in 100 infected? Is it 1 in 1,000 infected? Or is it what this person's saying? Is it really 1 in a million of those people infected actually are causing people to pass away? So it's so rare to die from COVID, right? One of the tidbits you'll see is a lot of times people will post this statistic of like this number, and a lot of times you'll start seeing most people don't understand statistics. So it's always important to make sure people understand what they're posting or help correct them if they post things like that. So let's go into it. So this is actually my life back in medical school. And I know SARS came out at the tail end of my medical school career and some of the time when I was in residency. But this is kind of what I remember learning about coronavirus. I remember some rhino holding a corona, and he had a cold. This came from this book called Microbiology Made Ridiculously Simple. Some of you guys may have had this. I know this is one of Dr. Zhao's favorites. And basically, this little blurb is all I really remember about coronavirus, that it's the second most common cause of the common cold, and mostly kids get it. And I thought that was kind of interesting, and I didn't really think much of it. I thought, I used to joke around with patients saying, like whoever thinks of the, common colds, people get, reinfecting, get a little bit of the sniffles. And I used to say, what's the chances, common cold's ever going to cause a problem, or, whoever comes up with the cure for the common cold is going to be a billionaire. Well, it's evolved over the last year. So I was primarily only outpatient. I did 4 weeks inpatient, and I got reallocated inpatient due to how crazy this was. I mean, I remember talking to my boss for my merit review in January of 2020, and he told me he was hearing internally this is going on. And this is early January. And I remember talking to one of our infectious disease experts thinking that, based upon what Wuhan, China reports, they thought it wasn't going to be as bad as what they were saying. And then lo and behold, a year later, we're here. And as you see, this is actually a really good resource, and sort of what I'll be doing during this talk, too, is trying to give you guys skills and tool sets to go answer your questions. Johns Hopkins has an amazing dashboard that you can search. You can search the COVID-19 dashboard, Johns Hopkins, and it'll actually tell you basically all the data you need to know, where the infections are common, what are the global case rates, what are the global death rates, how many people have recovered, how many deaths there have been, and so forth. And you can get really specific up to the state and even the county, I believe, to figure out what's going on. And it can tell you lifetime daily cases and so forth. You see in these little box here. But specifically to answer our question from before, right, the global death rate is about 2.5 million. The global case rate is 115 or almost 116 million. So it's about 1 in 45 people die of COVID. And I calculated it out for the United States specific population. It's around it's about 1 in 56 or 1 in 60. So I want to preface that, that sometimes people are saying that number might be inflated to be a little higher because people weren't testing, but also don't forget too, back in the day, we probably were not counting for everyone that passed away for COVID. So I don't think that number is that far off. And that's the reason why we take it more seriously, is because, with a number of basically, a 2% chance of passing away, and that's equivalent to the 1918 flu pandemic, we have to be very careful. And that's why we took this, what we did, and we did a lot of the isolation, quarantining, and we've adjusted our lives as such. I brought the slide in here. Feel free. I will try to go over it quickly because I know for some of you this might be overwhelming. But I want you guys to at least understand what's going on with people with COVID. This is a COVID viral particle. It's a positive stranded RNA virus with a nucleocapsid in there in an envelope as well. The thing I really care for you guys to remember out of everything here, all these words, is basically the way all this all occurs is they have these thing called spike proteins that literally look like spikes, and they attach to the ACE2 receptor. There's a couple of things they do. First, they actually get into the cell through the ACE2 receptor and replicate through different variety of hosts. And the next slide will go over this, the different organs that are involved. When they actually bind to this receptor, it actually causes some cytotoxic effects, meaning the cell itself and the surrounding area will actually start releasing a cascade, which will cause inflammation, which we'll go over here. This binding itself actually prevents angiotensin 1 and 2 from being converted. As a result of that, there's dysregulation of the RAS system. The third thing that happens is when this thing binds, it actually causes sometimes the cells to either lyse or have apoptosis, because when they lyse, when they're getting replicated and the viruses shoot back out. And as a result of that, what it does is it causes thromboinflammation, meaning it decreases fibrolysis and increases thrombin products. And this is what we'll discuss at the very end. And four, basically what happens is that for some reason, unclear to us, is that the T cells get basically unregulated, meaning they get lymphopenia. They start not being produced anymore. And then there's all these interferons and signals that basically, and cytokines that get released. It's not truly a storm. I know that's used, but a storm usually refers to someone being like completely hemodynamically unstable, and these patients are stable minus their oxygen in most cases. Sometimes they can have heart damage that can make them unstable, or strokes and so forth. But basically what ends up happening is we damage all the tissue in the blood vessels. And as a result, the body tries to repair it. This inflammation from this whole process is occurring, and you throw basically a bunch of microthrombi everywhere. And that's what you see. So when you start getting people sick, what occurs, right? So the lungs that you're seeing, this is one of the misnomers that forever we thought this was like a true infectious pneumonia you're looking at. A lot of it's actually small little microthrombi you're looking at with those x-rays. That's why the procalcitonin or a thing of inflammation is usually on the lower side, right? Or the kidney involvement, right? So the ACE2 receptors involved there too. So what you start to see is you get people with nephrotic range proteinuria because you're actually destroying some of the podocytes and so forth in the capsules. So protein's starting to leak. And ironically enough, the nephrotic syndrome tends to resolve itself. But there's a series of issues, and I'll leave it here for you guys to see. But basically, you can get skin manifestations. Your pancreas can be less effective. There's some stuff. This is more the lymphopenia. A lot of diarrhea, GI symptoms, liver issues. I've literally seen healthy 29-year-olds literally get put on a balloon pump, and I've seen people have heart attacks, strokes, you name it. The microthrombi are real, and it causes these. This is basically the effects of what you see here and this slide. And what happens is usually in most cases, it just takes time for the body to kind of repair itself to get out of these complications. So, summary of this section. Death from COVID-19 globally is about 1 in 45, and I recognize the limitations of that calculation that more or less people may have actually been infected or not counted for. COVID-19 enters through the spike protein ACE2 receptor. It causes interactions that lead to dysregulation of lymphocytes, inflammation, cytokine releases. It causes apoptosis and endothelial cell damage in the blood vessels. And the downstream regulation of this leads to those microthrombi and all the end organ damage we just discussed. Next section. So demographics and risks. Doc, you probably heard this question before, or something similar to this, right? Doc, my BMI is 30, so that would be someone that would be obese, and I have asthma. Am I really at higher risk to get hospitalized with COVID-19 compared to the general population? And I think that's the key, getting hospitalized, right? Think about that. Yes, no, or you don't know. So this is some basic demographic data in regards to who, two factors. One, conditions associated with increased severity when you are sick with COVID and hospitalized. And basically, if you see this list here, over here, most of the cases, it's basically, you can kind of simplify it as anyone with more health problems is going to be more likely to get sick. It's interesting. This is per the CDC. From my own anecdotal view, I actually did not see many pregnant patients. I don't recall a single pregnant patient. Some of these people that are on some of the immunomodulator therapies for like rheumatoid arthritis actually did better. And then when I was talking to one of my colleagues at Hopkins, they actually said some of the transplant people didn't do as bad as they thought. But in general, basically, if you were to simplify it, is the more health problems you have, the more likely you're going to do poorly from the disease. Some things also that we're saying are more likely to be hospitalized. Age, so the older you got, the more likely you were to be hospitalized. Also increased risk of death. Race, so non-Caucasian patients tend to do worse. So specifically Blacks and Hispanics, and we'll have a slide on that in a second. Men, on average, are more sick than women. For some reason, announced to me, and I was not able to find more data on this, people that smoke are slightly less likely to get COVID, which is weird, and they don't understand it. And then the blood type. This is the one that you guys probably hear about all the time. So if you have blood type A, you're 59% more likely to get severe COVID. And blood type O, you're 39% less likely to get severe COVID, which is, fascinating. And I mean, that percent likelihood is probably not that big. I think 59% versus 39%, definitely any percentage change is not different, but in the grand scheme of how likely you are to get it, it's probably doesn't make much of a difference, but enough to be noted. This is another thing I want to focus on too. So this is a teaching point I want to go into. And before I go into the teaching point, the one thing I also want to note too, this is the first time in decades that we actually seen the life expectancy. I think it might be close to a century. I think it was since one of the world wars, or actually one of the last flu pandemics, is that you actually saw the life expectancy go down by a full year in 2020. So we were at 78.8 years, and now we're at 77.8 years, which is shocking, right? And these are the most common, and specifically what you're going through here, these are the most common issues of people being hospitalized for COVID. One of the kind of things I wanted to bring about is that what about their actual risk to get infected? So don't forget, right, that even though 40% of people that are being admitted are obese, you have to think about one other thing, right? Like how many people in the population are obese, right? Or how many of the people in the population have hypertension, or how many people in the population have diabetes? And the thing that's a teaching point here is that people, as I probably already said this, statistics people don't understand. So they'll start throwing these things out on like news media and scaring everyone. And what we actually find is there's only a few things that people are actually coming in more frequently with when they have that condition. So for example, diabetes, right? These are so I listed 5 common things here. I mean, most of these are actually very similar to the general population statistics. But this is what percent of the population has this in real life. So about 45% of people have high blood pressure. 40% of people are obese by BMI standards. 1 in 8 people are diabetics, or 13%. 1 in 12 have asthma, and about 1 in 8 have some form of heart disease. And if you look here, that's not far off. The only one that is really far off is diabetes, and I actually don't know any research beyond it, but it seems to be about like 33% of the people being hospitalized have diabetes, yet it only, the general population is only 1 in 8. So that's something important to know, that because it seems like diabetic patients, if you were to ask me that honest question, are more likely to get hospitalized compared to their general population. Compared to if someone's obese or has asthma, I would actually answer that question from before saying you aren't actually increased risk to get hospitalized based on those 2 factors. You do worse if you do get it, but you're not at increased risk to actually get hospitalized when you actually look at the data. And this is another thing too, and actually highlights something we're going to talk about later, is things like the Caucasian population. I only included up to Connecticut. If you go to the Kaiser Family Foundation, you search vaccine rates per ethnicity, you can actually sort this out by Black, Hispanic, Asian, and white. And this doesn't highlight it perfectly, but basically what it shows is the number of people vaccinated in general that are Caucasian tends to be more than the percent population, and the percent deaths tend to be less as well too. So when you start looking at African Americans, I think Alabama is probably the best case, and that's not the exception. I would say Alabama, if you look at the other 44 states, is kind of where things are. And you see here, the percent, 19% are getting vaccinated. It makes blacks make up 30% of the deaths, yet they're 27% of the population. So they are not getting the vaccinations that it should be, and they're actually dying at a higher rate than what's expected. And the same is true for the Hispanic population. And I want you to be aware of that. The answer of why this is occurring is extremely complex, which we won't discuss today, but basically a lot of it's equity-based issues. So it's things like access, availability to health care, and so forth, and a variety of other things. Like, for example, in the Hartford community, the poor demographics of Hartford did not have access to for testing compared to people that were wealthy. And that was something that was told to me, which was fascinating. Which you can imagine can affect things. If you don't know you have COVID, you might present later to the hospital. You might have a higher chance of passing away. So here's the conclusion. So basically, in general, older patients and those with multiple health conditions do worse with COVID when infected, something you probably already knew. However, these are the people that are more likely to be hospitalized if they, and are expected to be in the hospital and get COVID-19. And these are things like diabetic patients, hypertensive patients, older patients, especially those over, I think, 50s when you start getting the cough, 60s really when you start seeing it, 60s, 70s, African-American, Hispanics, and A blood type. The next part, symptoms of COVID. I've been asked this question multiple times from my patients. Doc, I lost the taste, the sense, and smell. Does this mean I have COVID? So I want you to think about this, right? Which of the following physical exam findings are not commonly seen, or symptoms are not commonly seen in patients with COVID-19 pneumonia? So A, dyspnea worse with exertion, B, wheezing, C, fevers, or D, loss of taste and smell. So this is basically a conglomerate of all the types of symptoms people present with. The most common thing people explain or say is they get a fever. So most cases, about 88% of people that are symptomatic with COVID, and this doesn't look at people that are asymptomatic, right, because it's impossible to look at that demographic, but the majority of them get a fever. A lot of them will feel fatigued, shorter breath with exertion, as you see here. It's about 20%. But specifically, this dry cough is something else that happens too. And it's not one of these wet coughs that you can easily treat. It's more of a dry cough as a result of kind of the inflammation that we discussed before. Since then, there's been a few other things that have popped up that's been different than some of the initial studies from Wuhan, China. This loss of sense of taste and smell, they found that basically 70% of people report it when they're affected with COVID, which is pretty unique to this disease process. The other stuff, too, that happens is confusion. Some people get an encephalitis. I'm sure some of you guys have been consulted about this. And it's kind of interesting. They call it COVID encephalitis, and usually older patients or patients with memory issues tend to be at higher risk. But the one that's actually more interesting to keep in mind is a lot of people are starting to report GI illnesses. So actually, when you ask somebody that's been affected with COVID, you'll say to them, they'll basically tell you something along the lines of that they had diarrhea right before they had it, or they had some GI upset, or they had nausea and vomiting. So I think there's more of a GI involvement. And as you saw, too, there are ACE2 receptors in the GI tract. So they probably actually are involved in some of the early transmission of COVID, which we're still trying to figure out. Specifically, though, too, when patients present and when they do contract COVID, about 20% of the patients are not going to have any symptoms at all, versus 80% are going to demonstrate some symptoms. Specifically taking that 80% and looking of those that are symptomatic, I know that 80% of them are going to have mild symptoms or mild pneumonia. So a lot of the times they say mild, moderate, severe, and critical. They're talking about the respiratory symptoms, because about 85% of why people are pass away, or at least contribute to, has to deal with the respiratory concept of this. But in most cases, 80% of the time, it's this mild symptoms. And mild symptoms meaning they're not hypoxic, meaning their oxygen's over 94%. And they may feel fatigued, they may have shortness of breath, they might have mild fevers, you might have that taste and smell loss sensation, might have diarrhea and so forth, but they're not going to be needed to be hospitalized. 14% moderate to severe, and it's anything under 93% and a respiratory rate of 30. I think that's kind of, I would look more probably so at the oxygen saturation. And in most cases, some of them don't need to be hospitalized, right? Because, if they're satting above 90%, I think that's most institutions cut off. They're not eligible for certain therapies, which we'll discuss later. But if they sat lower than that, and that is their thing, that's usually when they get started on oxygen and get kind of admitted to the hospital section for treatment for COVID-19. In critical of it, it's 1 in 20 of them basically are going to have shock respiratory failure. And about the average duration when they do get ventilated in the ICU is about 2 weeks. And that does include people that pass away. This is a timeline of symptoms, which is pretty important. So from the day you first start showing symptoms to when some of these things start to occur, this is the kind of the key thing. So I think the key thing for you guys to know is about 1.5 weeks is when people start getting super sick. So if you start showing symptoms and you make it 2 weeks, you're probably not going to be one of these people to get one of these series of injuries. But most of it is when you start presenting with sepsis or you start doing a hypoxia, that's usually day 9. ARDS usually progresses after that, so the point where the high flow oxygen and other ventilation efforts that now needing intubation usually progress within 3 days of the admission, as you can see too. And in some cases, it's literally a day. In most cases, I would say it's anywhere between this 10 to 12 days. I would say just anecdotally, it usually takes people about 3 days to really start seeing this. The other stuff that you start seeing, too, is cardiac injury. So people are getting heart attacks. People are getting troponin leaks, which are thinking from this microthrombi in the small vessels of the heart. They're getting the kidney injuries. So I remember one of my friends was very proud of himself. And actually, I was impressed, too. He diagnosed COVID because the person had nephrotic syndrome on a UA because they really thought the person had a UTI, and this is during the summer, and it ended up being COVID. He's like, no, I think this is the COVID syndrome we're talking about, and he was correct. Other secondary infections, and a lot of the times the secondary infections are secondary to being ventilated or being in the hospital longer, and that actually is a big reason why people pass away, and usually around 3 weeks being from the day of symptoms is the average time someone passes away. It's a little 2.5, 3 weeks. Typical duration of symptoms, this is something you'll see too, is usually takes 12 days from the start of symptoms for the fevers to subside. Usually takes about 2 weeks for shortness of breath to subside, and the cough can persist for up to about 3 weeks, which is annoying for patients. I would recommend using dextromethorphan at 30 milligrams Q12. It's been shown to be the superior medication for cough in general and suppressing cough, even more so than codeine cough syrup. It was one of the things that was been imparted on me, and as a hospitalist and a resident back in the day, I actually would give it to people and watch how much they coughed, and I was dumbfounded it actually reduced the cough. So it's one of those medicines I tell people a lot of times the over-the-counter dosing is actually too low, so they actually don't get the benefit, which is interesting. Anyhow, here are the conclusions, right? Mild symptoms usually last for about 2 to 3 weeks. 20% of people are asymptomatic. 80% of them are not. Of those that are sick, 80% are going to have mild illness and never have to go to the hospital. The most common symptoms you'll see is cough, fever, loss of taste and smell, and some GI symptoms and body aches. And the thing I want to highlight too, this is important, and this answers the question, is true pure COVID pneumonia. And I think pneumonia is kind of a pseudo misnomer. Lungs sound totally clear. So this is an anecdotal experience. I remember it was me and like 3 other guys were pulled in, and we were all in our mid-30s, and we were taking care of the COVID unit. You guys remember this too, how crazy it was. And one of the things we noted, and we were talking to each other, like, this is odd. Every time we were listening to the patients, we didn't hear any, like, the typical wheezing and, bronchi here with pneumonia. And while we were talking to each other, we thought first, because we were using the plastic stethoscopes that were broken, and we find they weren't broken, actually. It was that they actually do have just diminished breath sounds. And if you think about what's there, if it's microthrombi don't make noise. So it's like almost think of it as like group 4 pulmonary hypertension in a weird way. It doesn't sound like anything. You can end up getting a COPD flare that has these wheezes, and that has happened. You can't, in most cases, when people are ventilated, they start making noise due to concurrent secretions and maybe a secondary infection. But when it's pure COVID coming in, they do not sound wheezy, rhonchi, and so forth. So that's actually a misnomer. And it's actually one of the reasons back in the day when we were intubating people early is it looked like ARDS. So Roy Brower, someone I worked with when I was at Hopkins, he came up with ARDSnet. And given the appearance of the X-ray looking like ARDS, we were putting everyone on an ARDS protocol. And it was actually increasing mortality because the compliance of the lung is the same as a regular lung. So it was actually due to all that inflammation that we showed on the pathophysiology slide, was injuring the lungs more, and actually people are doing worse. So we actually went from going from 6 liters nasal cannula immediately to intubation to basically doing everything possible not to intubate somebody, because usually when someone does get intubated, their outcomes are usually very poor. So that's something that has evolved over the last year. So we'll go to the next section. Testing recommendations. So this is something you probably get asked about all the time, right? Doctor, I was exposed to someone with COVID-19. What should I do? So I want you to think about what you would recommend for this patient, right? Would you tell them to test immediately? Would you tell them to wait 72 hours if they were asymptomatic? Would you go tell them quarantine for 14 days and tell them if they don't get symptoms, don't worry about it? Or would you, just tell them, just go live your normal life and don't worry about quarantining? And I've, ironically enough, have had people tell all 4 of these answers from what I've heard from patient anecdotal experiences through this last year. So this is what Pearl, and this is something I think you guys all should know, is maybe this is like my choosing wisely concept, right? I guess we're putting in high value care here. Do not test asymptomatic patients immediately after exposed. And why is this, right? So this is one of the biggest mistakes. And it's one of the hardest things to kind of tell patients, no, we actually aren't going to test you right away. The reason why is you actually won't start detecting the virus until at least 3 to 5 days from when they're exposed, which is interesting, right? So it makes sense. You're going to get hit with a series of particle, and what's going to end up happening is the particle itself has to kind of replicate inside of you, right? So if you test them too early, what ends up happening is people get tested, say, with a rapid antigen on day 0, the day they're infected, and then they're negative, and then they kind of let down their guard, and then they go around, and then day 5 occurs, which is the mean onset of start of symptoms, right? And they've exposed a bunch of other people to COVID-19, including their own family is usually the risk. The important thing to note is this, right? So the mean time for symptoms onset is 5 days. And the other interesting thing is the peak being contagious is at 5 days too. So the day you present with symptoms is the day you're the most contagious. So if you think about this from a curve perspective, right? So half of this, so where you're ramping up and you're infectious, you don't even know you're infected. So in other words, basically, for 50% of the time when you're infected, you have no clue you're infectious. And this is interesting to keep in mind. And we'll talk about some of this other stuff with, when you're developing symptoms on the next slide to advise people when to get tested. But it's interesting. There's the longest reported incubation period to date is 24 days. I've heard internally at UConn, there's been some people on another side note that after they've been infected, they've been infectious for over 50 days after, which is kind of crazy. So, I think it's something to keep in mind. Those are the outliers. In general, usually if you go at least 10 days from when you first develop symptoms and you don't have a fever for over 3 days, you're no longer infectious. And that has been holding true for most people. And I want you guys to at least know that. But specifically in Connecticut and the CDC, and they're both aligned, what should you tell people if they ask you they need to get tested, right? Because as I told you, you guys are probably the front lines for some of these people. And basically, there's 3 things I would tell you to do. And I know that these 2 are kind of the same. You can either tell somebody if they have symptoms, obviously, you tell them to get tested right away. And these are people that are asymptomatic you're advising. The first thing to do is you tell them to quarantine for 2 weeks. And they don't need to get tested. If they have no symptoms, they're good to go. The second thing you could do, and this is the risk of them being still infectious if you tell them to quarantine for 2 weeks and then go back to their daily routine, is 1 in 1,000 people you'll miss. You can tell them instead then, let's say 10 days and don't get tested. And if you do that, and some people are starting to do that, the risk of being still infected and meeting out that beyond that peak window, right, of showing true symptoms of COVID-19, it's about 1 in 100 you're going to miss. The other ones that are becoming more favorable in other states is you can actually wait 7 days and then do a rapid antigen or a molecular blood test, usually around day 5, 6, 7. And if that's negative and they've had no symptoms for 7 days, you have about a 1 in 20 chance, roughly, of still getting COVID, or a 5% chance, which is important. So all 4 of these are options. I would actually keep this for your own records. I think the safest, obviously, is quarantine for 14 days. For stir craziness, you can add 10. They've never actually looked at if you antigen test them here, what's the chances? I would say if you antigen tested them here at 10 days, the chances would be slim to none. So some people are starting to adapt that model, get them to 10 days, rapid them at the 10th day. And if they're negative, then you can tell them pretty certainly they're not going to get COVID. And here's a summary of this section 2. So basically what I want you guys to know is don't swab them immediately the second they tell you they've been exposed. And here are the effectiveness of waiting 14 days, 10 days, and 7 days. Effectiveness of isolation and masks. This is something that pops up all the time too, right? Doc, these masks don't work. Give me proof that they will work and I'll wear them. Haven't you had this conversation probably on Facebook, Twitter, or with a really obstinate family member, right? I will go with this, and this is something you guys have probably been thinking about. What are the cases of flu nationally in the United States in 2020 to 2021? Has it been 1,500 cases, 50,000 cases, 100,000 cases, or 450,000 cases? Well, I was shocked when I saw this. There's been only 88 cases in Connecticut, and as of March 15th, 2021, because I couldn't change this every day, there's only been 1,500 cases in the entire United States. And this is, trust me, I've asked my colleagues, I'm like, have you even seen a case of flu? And they're like, no. Or you ask like pediatrics, they're not seeing it. So this mask actually work. And this is shocking. And normally in a season, right, you get millions of people infected and you get hundreds of thousands of people hospitalized and you get tens of thousands of deaths. Last year, there was 33,000, I believe. And you're asking yourself, like, why is that, right? And I'll tell you why that is. It's something called the R0 phenomenon. R0, some people call it, but R0 is how you pronounce that little weird lowercase o, R0. And basically, R0 is a simple term that says, when you get sick, how many people are you expecting to contract the disease as a result of you being sick? And this actually, R0s are calculated as if you were taking no precautionary measures whatsoever. COVID-19 and typical colds are actually around 2.5. So SARS is about that time as well, too, versus things I think like measles. I forgot what it is, something crazy like 12 or something super high. And influenzas are not as 1.5. So to translate, if your R0's 2.5 like COVID, 2.5 people you're expected to infect per person if you were to use no standard precautions. Versus flu, in the 1918-1919 influenza pandemic, it was 1.5, and the typical flu season is 1.3. So what you're actually finding is the precautionary measures, and what it is basically the mask and isolation and gloves and so forth, and the hygiene that we're suggesting, it's working, and it's more likely to work at the lower the number is. So it actually almost completely eradicated flu, which is amazing. I mean, there's only been one pediatric death, at least to my knowledge, to date. And some are quoting 0. So one is the one I at least understand the most. And part of this is actually awesome that it's finding that these masks work. And there was a study out of Duke. This is a compilation of the information I wanted you guys to know, is basically which mask should you recommend for a patient. So, as you know, we always are the ones to be using these two, right? So in medical care, you should be using an N95 and a surgical mask. And they're basically both. An N95 is almost 100% effective, versus a surgical mask is 99% effective at preventing, COVID-19, basically, which is shocking, right? So even if you were to literally go into a room with someone with COVID-19, you're wearing a surgical mask, your risk of getting COVID-19 is actually fairly low. The longer you're in there, the higher the risk. And they say more than a 10-minute exposure usually is needed for the normal strains. to get someone infected. But as you see here, there's a variety of masks, and I think the normal silk mask for the average person is okay, and they're starting to say the 2-layer cotton mask might be a great option for people that want the homemade masks. But even T-shirt made masks are 97%-ish effective. But the thing I want to let you know is you should recommend 2 things when you see this. You should actually tell your patients or tell your friends. If you're really, about it, you can tell people in the streets about this stuff. There's 2 things you shouldn't do. 1, you shouldn't recommend people to wear the gaiter or the scarf, or 2, this valve mask. This is actually extremely dangerous because what ends up happening is you actually start shooting out particles back out into the community, and you're extremely infectious. So here's a summary from the slides here. On a given time, I will pick up a little bit just to make sure we go through the rest of the slides, but here you go. Diagnosis of COVID. What symptoms are more specific for COVID-19 as opposed to influenza, typical cold or common cold? Is it fever, cough, sneezing, or shortness of breath? So here's a slide here, and it goes over all 3: coronavirus, flu, and colds. And as you see, the teaching point is if someone has symptoms, you should really test them for both flu and COVID-19. You shouldn't test one or the other because it's nothing really specific. But if you were to ask me, is there certain things that if someone tells me this, I think pretest probability COVID versus instead of flu, I would say 1, loss of taste and smell that's sudden. That's one thing that's reported. 2, if they're reporting a sore throat, that's actually more common with just the common cold. And the other thing too is this exertional shortness of breath. That usually isn't seen with the other 2. And as you see too, I don't agree with this. I think body aches are seen pretty commonly with COVID as well too, but it's something for you to keep in mind. So even though these symptoms are here, I will stress to you guys to keep in mind, if you see somebody that's coming in with COVID, most likely just assume that they have it and test for both COVID and influenza. And they're identical to treatment. And here's some of the labs, and this is important for you guys to know. People with COVID, the most common symptoms, or at least be aware of, is lymphopenia, right? Because I told you it down-regulates the expression. You also get stuff where you have increased C-reactive protein, increased liver enzymes, the procalcitonin, which is a marker of infection, is usually normal. And out of all this, to keep in mind, the 2 prognostic factors are worse is lymphopenia and an elevated D-dimer. So COVID-19 basically is the same as, presents almost identical to flu, except you might get more shortness of breath and loss of taste and smell. The things that are most common that you're going to get lab findings-wise is this lymphopenia, thrombocytopenia, so little lower platelets and elevated inflammatory markers. And an elevated D-dimer and lymphopenia are associated with worse prognostic outcomes. Therapy. So we'll discuss a little bit of the therapy here. I'm not going to go too crazy in it, but at least get you guys in the basis of why we're doing what we're doing. Go from here and at least go over one key thought that I want you guys to be aware of. So this is a patient question I've seen before. I just found out I tested positive for COVID-19 because my partner showed symptoms. I'm currently feeling fine. Can you prescribe me prednisone? Because I heard it's the only therapy that works for COVID. Do you answer yes, no, or I say, I don't even know what prednisone is, right? This is a rapidly evolving experience. I tell you, this has been one hell of a year. Literally, I remember in the beginning of this pandemic in 2020, they were saying steroids are bad, and this is the study that pushed that. And then in the start of the pandemic again, when it got wave 2 or phase 2, as I like to think of it, it happened more in the fall, the winter. Everyone's touting that this is the life-saving therapy, that only thing out there that's actually reducing deaths, which is just amazing to see how these things change, right? In general, if you were to have a summary slide of what you should and should not recommend, if they're not hospitalized, there is some of these monoclonal antibodies, which are, which you can offer, which is decreasing the viral load and decreasing number of visits. It has not looked at if they're actually getting more or less sick. There's vaccines, which I strongly recommend. Obviously, proper distancing, hygiene, and social distancing. Oxygen. Do not use steroids, which we'll discuss, and possibly convalescent plasma. When they're hospitalized, things to be thinking about is steroids, oxygen, and proning, which I like to think of it for the parents in the room as tummy time, where you actually flip them on their stomach back and forth. That actually has been shown to actually help a lot. And possibly remdesivir and possibly convalescent plasma, which we'll discuss a little bit more. So basically, just so you guys know, steroids are not recommended because when they looked at this study, which we'll show in a second, it actually increased all-cause mortality. So the only thing they've actually been proven to work in the outpatient setting is nothing. I mean, it's literally just watch your symptoms, put an O2 monitor, have close follow-up, and if your oxygen drops or you were to develop one of those other side effects, go to the hospital, and then you can start therapies. The antibodies may or may not work. They're not sure, and I'll discuss why in a couple seconds. Steroids. Why can't you give it in the outpatient setting, right? There was a recovery trial, and this has probably been the biggest study that's been to date for treatment. It was 2,100 patients. They were given 6 milligrams of dexamethasone for 10 days. And basically what they saw was just for people needing oxygen with an oxygen saturation 90% or less, it decreased 28-day all-cause mortality from 23% to 26%. It also reduced the risk to be ventilated, which is huge. So it went from like about 30% for the people treated to 40% of people needed to be ventilated if they didn't get steroids. And it also reduced deaths from patients receiving supplemental oxygen. Now, the important thing is that it actually showed that people that didn't need oxygen increased the risk of death, where you actually had a risk of 18% of dying if you got steroids, if your oxygen was above that 90% threshold, versus 14 from placebo. So that's the reason why we say do not give outpatient steroids. Do not do it. If your friends get on it, if you're told to get on it, just say, thank you, I don't want it, unless your oxygen truly drops. These monoclonal antibodies use an outpatient setting, so I am not even going to bother trying to pronounce these. I tried bamlanivimab and casirivimab, and I'm not even going to go there. And honestly, I sometimes think you need a PhD to pronounce it. But basically, to summarize both these are promising therapies that are out there for monoclonal antibodies, specifically to the ACE2 receptor and that protein spike. And what they're showing basically is that they're lower viral loads and they're coming to the hospital less frequently. And these are the two studies that are in here, and they're in phase 1 through 3 trials. In most cases, the only people that are eligible for these therapies are people that are super high risk, and it's usually immunocompromised patients or patients, if they were to get it, they would have a high risk of passing away. So not your typical obese patient, but your patient that, say, it was getting treated for cancer, would be an example. Remdesivir. Some hospitals don't use it, some do. Why is that? So there's the NIAID trial that looked at about 1,000 patients with COVID-19, and the recovery day, basically, this is the reason why they say remdesivir works, and now I got approved. When you looked at randomized placebo-controlled trial, what they found is they were hospitalized 5 days less if they were given remdesivir, so 10 days versus 15 days if you were given placebo. That's actually the only positive outcome that's actually come from remdesivir, which is interesting. Solidarity trial looked at 11,000 patients, looked at 30 different countries, and run by the WHO, and it showed it had no change in mortality. So as a result, the WHO actually does not recommend remdesivir, and I know we use it. But what we might be actually using is a really expensive $2,000 therapy to reduce someone's length of stay without actually changing their long-term mortality. Convalescent plasma. So I will summarize without going into too much detail. So basically, what happened was they did a study. They looked at about 100 patients. It was an open-label trial, and they were giving convalescent plasma to one group and not, giving placebo or standard of care to others, right? And what they found was there was no improvement between the groups. But the problem with this, and the reason why we're still using convalescent plasma, and I recommend considering it, is one, they found that they needed 200 patients to make this discussion, which they underpowered the study. So they actually couldn't make this conclusion based on what they found. And the other thing is they don't measure antibody levels in most states for plasma. So meaning if you order convalescent plasma, you may be getting like nothing, and you might actually be getting like a super high level of convalescent plasma. So in Delaware, they will actually measure these things, but in other states, they don't. So convalescent plasma is still out there. That's why we're still not sure what to do with it, because basically there's studies have showed no difference, but there haven't been really powerful studies. So more research needs to be done. And the studies are now looking at concentration of convalescent plasma or patients' antibodies that have previously been infected to see if they make a difference. I'll bring this up briefly. This is a great site to actually go on, which I'll say opencriticalcare.org, and they have a dashboard, and they'll actually tell you what you should do, should not do, and what we're not sure about. So for you guys to know, for home therapies, what they recommend at this point is get people vaccinated, wear masks. It's okay to take NSAIDs. Do not, don't give steroids to people that are hypoxic. It's okay to give them if they're hypoxic. Proning is a big thing. Giving high flow oxygen if they're hospitalized, and standard dosing. DVT prophylaxis, right? Things that don't work, ivermectin, azithromycin, ACE inhibitors, hydroxychloroquine. You've seen the list of stuff that's probably been trialed. ACE inhibitors do not work despite that receptor. Things that may work, and this is the convalescent plasma, remdesivir, and so forth. So here are the conclusions here. We'll try to go through the vaccines, and then there's one other thing I want to show you guys because I'm running close to time. This is something that people get asked about. Doc, what vaccine should I get? And this is a slide basically that summarizes the effectiveness of all the vaccines. We don't offer AstraZeneca in the United States. There was some concerns of blood clots, which I think they just confirmed wasn't true. But basically, Pfizer and Moderna are a 2-shot series, usually given about 3 to 4 weeks apart from one another, and they're 95% effective. And when you get both of them, it's actually a very low risk of getting reinfected, unless you have a comorbid health condition, usually that puts you at risk. Most of these people that got infected, that roll over that number, are actually between shot 1 and 2. Johnson & Johnson's this new single-dose vaccine that's about 2/3 effective on 1 dose. So one of the things that comes up, and one of the things I just want to briefly mention, teaching point is one of the things people say is, I've noticed anecdotally, which I would agree, and most of you agree too, if people get the Moderna vaccine, the second shot, it is one hell of an experience, and they get high fevers, they get achy, shorter breath, and so forth. And the reason for that, I think, is actually 1 shot of Moderna is 80% effective per studies of actually preventing disease, versus Pfizer is about 50%. So I think what you're actually seeing at that is that you're introducing a high-dose titer, again, to somebody that's immune, and as a result, they're reacting to it. Which is the reason why Pfizer, you get less people reporting it, because it doesn't seem to be as strong of a dose. Because don't forget, Moderna is a higher volume you're getting per shot, too. So that's why I think you're seeing people that have more adverse events. And here are some of the side effects most commonly reported. Injection site pain is common. I would say I had that myself. Maybe I felt tired. And what the teaching point is about 50% of people are going to have muscle aches, headache, fatigue, and it usually resolves within 24 hours. Fever is usually about a quarter of patients. It might be a little higher with the Moderna vaccine. The other thing I want to bring up, too, this was the Connecticut eligibility for rolling out the vaccine. Apparently, it's fake news. They just changed it 2 days ago. And as of tomorrow, those are 45 and older are eligible, and April 5th, 16 and older are eligible. I want to mention here that it doesn't mean because you're eligible you're going to have access to the vaccine. It's still challenging to the vaccine, but I think you should encourage people to look further for vaccination. The other thing is, too, is there's a lot of mistrust in the in minority-based populations. So one of the things you should do is you should be an advocate for your patients that have mistrust, and I'm sure with psychiatric patients, too, there's a lot of mistrust as well. So you should be somebody that's forthright, saying, hey, this is okay, it's okay to be vaccinated. And with a doctor-patient relationship and trust, telling them that this is okay to do. And there's a whole discussion in this, which I can get into if anyone has any questions. So. Future research and direction. So I'm going to focus on a few things here. There's this post-COVID syndrome. About 50% of people get it after getting infected, and it can last up to, some people are claiming up to 2 months, if not longer. I mean, some people are still experiencing this. And it's basically feeling fatigued, winded. When you work out, you feel more achy than normal. And what you see here is some people get mild abnormalities that persist, and their breathing will be a little less. The other thing to keep in mind is after you get infected with COVID, 50% of people hospitalized show heart damage, which is shocking, right? And the significant effects long-term, we don't know yet. But the scary thing is like when you get the 25, 30-year-old, it's like, I'm healthy, I'm probably not going to get that sick. It's 1 in 3 people that are asymptomatic that still develop heart damage due to COVID. So this isn't something you can kind of tell people right away, hey, don't worry about it. You're a healthy 30-year-old, male. You're fine. I think this is something where we still might be seeing downstream effects to this that are, extremely severe. And I think that's the same thing, too, with mental health, that we're finding per the NHIS data, and this is something you guys are more experts than I am. They're actually finding that, anxiety, depression rates are up from 11% to 41%. And in the demographic under 50, it's almost close to 1 in 2 either report having anxiety, depression, or both. And some of that's probably the stressors of just isolation, children and so forth. But the other thing is, too, is our own healthcare providers are getting burnt out from the experience as well. It's something to be mindful of and ask each other how we're doing. The other thing I'll leave you with, and I won't go into detail much more just so I have time for questions, is fluvoxamine. This is something I thought was really exciting. I talked to one of my friends at Hopkins, and he was telling me this might be potentially a really awesome therapy we're going to try. So basically, there was a study out in JAMA in 2020 that used fluvoxamine, which is an SSRI. I don't know why I'm telling you guys. It's an SSRI. They looked at 152 patients, and they double-blinded it. And what they did was they gave 100 milligrams 3 times a day for 15 days. And as a result, what they found was that 0 people developed symptoms. 0. Which is shocking. Versus the placebo group, 7 people did. So they say this is a promising study. They're looking at it now too, but this might be some weird therapy that we never thought would actually work, but it might actually be something to prevent people from getting sick with COVID-19. This came out literally last night, and basically these are all the variants of COVID-19. The CDC is going to start actually labeling them as variants of interest, meaning they have genes that potentially can mutate to cause them to be more infectious or deadly, but they haven't shown that. There's been 3 of those. Variants of concern, so if you see here, there's 5 of them. Those increase hospitalization rates, and these are the ones you hear about in the UK, South Africa, Brazil, and then there's 2 now in California that have been shown. But the vaccine still works. There's some possibility it may evade, but the specific one is variant of high consequence, and these are ones that are more deadly. There hasn't been any of these, thank God, so far. But these are ones that are evading treatment, evading the vaccine entirely, or actually cause people to have high risk of death. So I will end here. So basically, hopefully by the end of this, now that you have at least a nice background to go over to answer your friends' COVID-19 questions, you'll have a framework to actually tell your own patients if they present with COVID-19 questions or family members or so forth, what they should do. And I think the thing I leave you with is this stuff is so rapidly changing, as I kind of highlighted with steroids therapy and all the other treatment options that's available too, is what we even understand of this. I think it's evolving, and every day you're going to find a little bit more tidbits out there. I recommend staying active in the literature, trying to keep up to date with it. If it's a new therapy, don't take it for granted, but at least give it some time to kind of pan out to see if it's really effective. And I know you're not going to be prescribing a lot of this stuff. But in the meantime, what I would recommend doing is actually recommend the vaccines, continue telling people social distance, because at least you can say 100% or now with confidence that it's actually protected against the flu somewhat. And just be out there to be an advocate for your patients. So thank you guys so much. Is there any questions from the team?
Great. Thank you, Dr. Steele. So
I'm going to stop sharing my screen if you're okay with that.
Oh, there we go. Yeah, that's great. Okay. So, if anyone has any questions, feel free to post in the chat, or you can email or text me. It's very interesting. So do you know why they studied the fluvoxamine out of, different, like, was it just an accidental discovery that maybe worked, or did someone have a theory about it?
It was an accidental discovery.
Okay.
Yeah. Andrew Caraba from one of my co-residents, he's an ID doctor now at Hopkins, and he basically told me it was like totally by accident, and it was like one of those, it's sort of like if you talk to me anecdotally, I didn't include it, like I've never really seen somebody that vigorously cardiovascular exercises gets really sick with COVID. It probably is protective. No one's studied it, right? But no one's looked at it. My guess is if you run on a treadmill regularly, you're not going to get that sick with COVID. Granted, age probably plays a difference. Versus like fluvoxamine, it's the same thing. They're like, wow, no one's getting sick with this. Why is that? And then they studied it and they saw it again, and they're like, wow. So now they're trying to actually go out there and see if this is real or not. I hear the studies. I heard there is a study going on. I don't know much more about it. I don't know where it's being held, but it's fascinating. Whoever thought you guys would be the cure?
I mean, I don't know that we can take credit for fluvoxamine. We had so there's a question here talking about monoclonal antibodies. So how would you give monoclonal antibodies as an outpatient? Are any of them oral?
No, they're both infusions. And basically what you would do is if you had somebody who was high risk, so say like your patient who is a cancer patient tells you, I was just, exposed to COVID or even diagnosed with COVID. A lot of the times there's institutional studies. You have to actually look this up. Yale probably is doing this. I'm not sure if Harvard does. I believe I've had some people at UConn go through, and you actually find the people doing the the infusions and you say, hey, I have a high-risk patient, can I do it? And they've actually given approval for that. There actually are people that enroll themselves into studies. So if you're not high risk, I don't know where those studies are in the state of Connecticut, but basically those are the only two means to get it. And it has to be infusion based. I've had a couple of people do it. And the couple of people I've seen have had more mild disease when they've presented to the hospital. Very little hypoxia, so it seems probably to work somewhat. But I think same thing with the history with hydroxychloroquine, which we didn't go into, is basically that first study looked at like 40 patients, and it said, oh, look, works because the viral load was low. But they excluded 6 people, and 3 of them were in the ICU. 1 died, another one transferred to the hospital, 1 just was lost to follow-up. So who knows if it really worked? And then the next study said basically it doesn't work. But it didn't really look at the right metrics, and it looked at it when they were already pretty advanced. And as I kind of already showed you on the slide with the viral particle, right, is all the damage might already be done. So it's kind of I kind of describe it to the person is imagine if I put a lion in a hotel room and they started destroying everything, right? If I took the lion out, the hotel room's still destroyed. So kind of what you need to do is prevent that lion from ever getting into the room, and that's where a lot of these therapies are going. So that's why some of this is promising. But I think, honestly, to actually completely reverse it, you're going to have to get a therapy where you're giving someone this almost prophylactically, and or you're identifying people that were exposed that have COVID and you're giving it to them. Because I think steroids reduce further damage, but I don't think nothing's going to probably reverse the damage, and that's what the therapies have thus far shown. So,
yeah, and I think the logistics of setting up outpatient infusion centers are difficult because infusion centers are often used for patients with chemotherapy, right? And obviously they are high risk themselves, so it's very difficult for places to be able to have COVID and also kind of the patients with cancer getting chemotherapy. So Dr. Sugarman here had a question about, can you tell us briefly about the long haulers and if there are any treatments yet for them?
The long haulers is that post-COVID syndrome essence. Well, there's 2 levels. There's people that are still sick, right? And there's some people that take a while. And I think that's kind of, in my opinion, those are the people that really got hit pretty hard, were in the hospital for a long period of time, were still hypoxic. And unfortunately, really the treatment is kind of waited out. In the post-COVID syndrome, to my knowledge, there's nothing either for that as well. So one of the things that's actually pretty disheartening, which I think is increasing mental health issues as well, is people are getting out of COVID and they're achy, they're short of breath, their exercise tolerance has gone down, they feel like crap, and they can't verbalize it more than that. But it's actually showing some of these people 2 months out or so, and some people literally have had this for like 6 months and they're still presenting this way, and they haven't found a solution to it. I don't know if it's just that was the damage that was done and their body's still recovering from it. And I honestly, it's one of those areas that we haven't even started really touching on to really, really research at the point, because I think we've been just trying to catch up with basics of hygiene and wearing masks, and what treatment to actually stop people from getting sick and pushing the vaccine forward. And I think that's probably the future, is actually look at this post-COVID syndrome, and you're probably going to see experts looking at ways to reduce it. My guess is, for at least anecdotally, people that introduce exercise, so similar like stroke victims, when they go through rigorous PT, it's not right away, but if they keep doing it, they tend to get better, because I think you get some vasculogenesis that occurs that may or may not help with what damage has occurred. That's what I've heard anecdotally. And in general, I think time. I think the body will recover for a lot of these people. 50% of them don't have post-COVID syndrome after a few months, but a lot of them do. And I'm sure you guys have seen it too, where you've had patients complain that they just feel awful after COVID. So.
Yeah, I think we're starting to see the ramifications of now that the pandemic's gone on long enough, from both the disease itself, but also the isolation, etc. There's another question here. Is it known how some people are asymptomatic yet still spread the virus? So I guess, what makes them asymptomatic? And is there anything different that spreads the virus compared to people that are symptomatic?
That's a good question. I don't know that answer per se. So like super spreaders, almost like typhoid Mary style. There are some people literally that don't ever present with symptoms and spread for weeks. They have documented a couple cases of that. They're called the super spreaders. I don't think they know why. I could ask my friends at Hopkins and get back to Ron, and Ron can let the group know. about super spreaders and people that are asymptomatic. But basically, in general, I mean, the fear that you have is it's kind of like when you don't know you have it. A lot of the times people are infectious, and it's sort of like mono similar too, where you're actually most infectious in mono, or a peak infection is when you start having symptoms. So that's why it's so infectious in colleges, because people go out and have fun and then they get sick and then they stop, but it's too late. They've already had fun. So it's the same thing with some of these viruses too. So yeah, I actually don't know why some people are more infectious versus others, but I can ask and see if there's any information. So and let Ron know.
Okay, great. Thank you. I think that's all the questions we have so far. Okay. So thank you so much, Dr. Steele. And, hopefully, hold on 1 second. I think Dr. Side just had a comment here. As a CL doc, I'm hoping that long haulers will teach us something about CFS patients, chronic Lyme patients, and other post-infectious conditions that can also become the wastebasket diagnosis, lightning rod for somatization, right? So, yeah, I think that, the worry for us is really about, our colleagues, you guys, are kind of on the front lines dealing with the pandemic and the acute phase of this. And as we move forward, the ramifications, especially for mental health and related things, are going to be very interesting and challenging, I suspect. So I think we'll have to continue our discussions on this. Yeah. All right. Well, thank you so much. Really appreciate your time.
Well, thank you. All right, take care. Bye.
Your call will be disconnected.